Cushing's, Addison's, and Acromegaly. Dr. J. Storrow. FY2. Objectives: brief overview of the pituitary gland. Brief overview of all three conditions. Review. Etiology. Presentation. Investigations. Complications. Prognosis. Brief case presentations. Revision tips. Pituitary gland anterior and posterior hormones, flat GP. F, FSH. L, LH. A, ACT. T, TSH. G, GH. P, prolactin. Posterior hormones, OA. O, oxytocin. A, ADH. HPA axis. Definitions: Cushing's, Addison's, Acromegaly. Increased glucocorticoid exposure. Addison's. Chronic primary adrenocortical insufficiency. Acromegaly. Increased growth hormone production. Cushing's. Disease versus syndrome. Cushing's disease is the result of a pituitary tumor secreting inappropriate ACT. Cushing's syndrome causes the same symptoms, but is caused by overproduction of adrenal hormones. It encompasses all other forms of Cushing's. Basically, disease equals increased cortisol from pituitary. Syndrome equals all other sources. Etiology: Harvey Cushing in 1932. Endogenous causes: 65% equals pituitary, 25% equals adrenals, 10% equals ectopic source, small cell lung Ca, non-pituitary, ACT-producing tumor. Exogenous causes: iatrogenic steroids, asthma, RA, palliative. Higher incidence in people with DM, HTN, obesity and osteoporosis. Equals females 5:1 ratio and ages 25 to 40. S and S Swedish S, spinal tenderness W, weight gain E, easily bruise. D, diabetes. I, intercapsular fat pad. S, stri. H, HTN. Differential diagnosis: pseudo-Cushingoid. Chronic severe anxiety and/or depression. Prolonged excess alcohol consumption. Obesity. Poorly controlled diabetes. HIV infection. Investigations: bedside. Blood tests, which and why. Special tests. FBC, raised WCC. UE, low K. Special tests. Cortisol at midnight and 0900, loss of diurnal variation, should be low at midnight, less than 550, less reliable. 24-hour urinary cortisol, 3 collections. 24-hour salivary cortisol sampling. Dexamethasone suppression test. Dexamethasone suppression test. Overnight low dose equals baseline reading, Dex 1 mg given at 11 p.m. Measure cortisol at 8 a.m. If cortisol low, less than 15 mol/L, equals normal. If cortisol high, greater than 15 mol/L, equals investigate further. Cushing syndrome. Localizing the lesion. Plasma ACT. If undetectable equals adrenal cause, as adrenal cause independent of ACT. If detected, proceed to high-dose Dex suppression test. High dose. If greater than 90% suppression, pituitary. If less/no suppression, ectopic source. Investigations: if any positive, imaging, CT of adrenals, MRI pituitary. If ectopic, CXR. CT equals/MRI of neck, thorax, abdomen. Management. Always split into conservative, medical, surgical, management. Drug therapy remains very important for normalizing cortisol levels. Medical treatment can also be used in patients who are unwilling or unfit for surgery. Miterapone, ketoconazole, and mitotane can all be used to lower cortisol by directly inhibiting synthesis and secretion in the adrenal gland. The treatment of choice in most patients is surgical, but the metabolic consequences increase the risk of surgery. Increased tissue fragility. Poor wound healing. HTN and DM, surgical treatment pituitary tumors, adrenocortical tumors. Transsphenoidal microsurgery. Radiation therapy may be used as an adjunct for patients who are not cured. Bilateral adrenalectomy may be necessary to control toxic cortisol levels. Adrenocortical tumors require surgical removal, can develop Nelson syndrome. Removal of neoplastic tissue is indicated for ectopic ACTH production. Metastatic spread makes a surgical cure unlikely or impossible. Bilateral adrenalectomy is indicated if necessary to control toxic cortisol levels. Prognosis. Patients with incompletely controlled Cushing's syndrome have a 5-fold excess mortality. Premature death in untreated Cushing's syndrome are caused by vascular disease, ME/CVA, uncontrolled DM and infections. The usual course is chronic, with cyclical exacerbations and rare remissions. The prognosis is better with surgery. The rare adrenocortical carcinomas have a 5-year survival rate of 30% or less. Addison's. Etiology. Dr. Thomas Addison in 1855. True Addison's. Affects 1 in 10,000 in UK-rare. Common presentation between 30 and 50. Affects women more. 70 to 90% have autoimmune basis, cytotoxic T cells. Clinical and biochemical insufficiency only occurs once greater than 90% of the gland is destroyed. Primary equals adrenals. Secondary equals pituitary. Tertiary equals hypothalamus. Etiology. Continued TB, most common worldwide. Infections, AIDS, fungal. Adrenal hemorrhage, caused by sepsis, meningitis. Metastatic spread to adrenals. Amyloidosis. Adrenalectomy. Genetic/congenital defects. Adgens equals long-term steroids leading to suppression of HPA axis. S&S. Investigations. Bedside. Blood tests, low NA, low cortisol. Low aldosterone causing high K. High adrenocorticotrophic hormone, ACTH. Low glucose. High TSH, indicates what? Imaging. CXR, Y. CT MRI adrenals. Investigations, synaptin test. Nightmare for busy house officer. How do you perform it? Measures cortisol. Short, no cortisol produced, no response. Long allows differentiation. Primary, no cortisol produced, ACTH high, equals adrenal. Secondary, cortisol produced, ACTH low, equals PIT. If initial cortisol is greater than 114 mol/L and second cortisol is greater than 400 to 500 mol/L, this excludes Addison's disease. Most common finding, the test can be performed at any time of day. Management. C.M.S., no surgical, conservative equals lifestyle. Medic alert bracelet and steroid card. Importance of not missing steroids. Intercurrent illness. If tolerating oral medication, then the dose should be doubled until better. Medical equals replace steroids. Glucocorticoid replacement. Hydrocortisone is the mainstay of treatment. Dose divided into 2/3 in the morning and 1/3 in the late afternoon, thus stimulating the normal diurnal adrenal rhythm. Mineralocorticoid replacement. This is usually required in primary adrenal insufficiency. Fludrocortisone. What else used for? Clu equals elderly who fall. Complications. Addisonian crisis. Severe dehydration. Pale, cold, clammy skin. Sweating. Rapid, shallow breathing. dizziness, severe vomiting and diarrhea, severe muscle weakness, headache, severe drowsiness or loss of consciousness, coma and death. Treatment of crisis medical emergency bloods, large bore cannula. Seek help if you suspect. If hydrocortisone. IV fluids. If glucose if needed. Prognosis depends upon the underlying cause. In those patients in whom the prognosis is not affected by the underlying pathology, replacement therapy should result in a return to health with a normal life expectancy. Acromegaly. Etiology: pituitary tumor greater than 99%, very rarely ectopic, carcinoid. MF equals 1 to 1. 30 to 50 years old. 5% genetic association with MEN1. GH stimulates soft tissue and skeletal growth through increased secretion of IGF-1 and secretion inhibited by somatostatin. S and SA, arthropathy B, BP high C, carpal tunnel D, diabetes and HF. E, enlarged tongue/heart. F, field defect, hemianopia. Investigations: bedside, bloods. Random GH levels, not helpful, stress/sleep/pregnancy. IGF-1 increased in 75% people. Special tests. OGTT. Measure glucose and GH at 0,30, 60, 90,120,150 minutes. Normally glucose causes GH suppression. If acromegaly, no GH suppression. False plus VES, puberty, pregnancy, hepatorenal disease, anorexia, DM. Investigations. Imaging. MRI pituitary. Visual fides and acuity. ECG/echo. Treatment: C.M.S. medical, somatostatin analogues, octreotide. Inhibit GH secretion. Monthly injection. Controls GH and IGF-1 in 60%. GH repeater antagonists, pegvisomant. Suppresses IGF-1 in 90% but GH levels rise. Can cause tumor size to increase. Surgical transsphenoidal surgery. Cures 80% microadenomas and 40% macroadenomas. Can try radiotherapy if surgery inappropriate, can take years to work. Complications: impaired GT-40%. DM-20%, GH counter-regulates insulin. Vascular, HTN, LVH, IHD/CVA. Malignancy, colonic polyps, controversial. Mortality 2 to 3 times, vascular risk. Case presentations. 30-year-old woman presents feeling unwell and dizzy, loss of weight, decreased libido and darker skin but also some areas of very light skin. Treated for anorexia 2 years ago. 50-year-old man presents saying his rings are becoming tighter on his hands and he's had to buy bigger shoes. Keeps walking into things. 30-year-old woman has noticed weight gain especially around face and abdomen, hair loss, bruises easily, urinating more often. Revision tips: look at the patient and around the patient's bedside. Think logically. S and S lead to what? Investigations, which leads to management, which leads to complications, which leads to prognosis. Management into conservative, medical, surgical. Investigations: start bedside, then move to desk, then walk to X-ray, etc. OBS: urine dip, ECG, BM, clinical exam. Bloods: IV fluids, VTE, anticoag, Cardex, meds. CXR, AXR, USS, CT, MRI. If endocrine, consider bloods for other pituitary hormones. Hyperprolactinemia is most common disorder.